Welcome to Psych Incubator and Eminent Psychotherapists Revealed. I'm Jeffrey Magnavita, and with my co-hosts tonight, Michael Albert and Elizabeth Magnavita, we are pleased to welcome back Christine Courtois to talk to us more about trauma. Christine is one of the leading experts probably in the world on trauma. She's written a number of articles, chapters, books, co-authored Post-Traumatic Stress Disorder with Julian Ford, who's another heavy hitter in the field, and has co-edited Spiritually Oriented Psychotherapy for Trauma. She has a current book out now on working with sexual boundary violations and understanding them in the psychotherapeutic process. So without further ado, I could go on and talk about all of Dr. Courtois' accomplishments, but I want to kind of get into our discussion this evening as soon as possible. So look on our site if you want to read more about her at Psych Incubator. So welcome back, Christine.
Oh, thank you very much for inviting me back. I enjoy these back and forths.
And for those of you who weren't here with us last time, Christine was the first guest on our series. And unfortunately, I did not press the record button, so we have that for further viewing. So now we're recording, so if you get to watch the whole thing, or if you want to show it to other people, it's going to be there.
Okay.
Thank you so much for joining us. It sounds like you haven't done nearly enough, but I wanted to start off by telling us how long you've been in this field for.
Well, I've been in this field for a long time, since 1971, when I helped to co-found a rape crisis center at the University of Maryland due to a series of rapes on campus. And I do think that it was the first campus rape crisis center in the country. Wow. So we were very proud of that. And I've been in the field since then. I have many times had people ask me, haven't I, become crispy fried? Haven't I burned out? And the answer to that is yes, occasionally I have. But I've always found the field to be so dynamic and changing that as soon as I begin to fritter away from it, something pulls me back. So I feel like my career has really followed the contemporary study of trauma.
That's amazing. And it sounds like your passions as well, too.
Yes,
that keeps us from,
it is.
Yeah.
That is true. So can you, for people that maybe don't know a lot about trauma, can you just give us just a brief synopsis of how you would conceptualize trauma in the clinical realm?
Well, I think trauma is an event or an experience, and it can also involve witnessing, that is overwhelming for the individual, physically, psychologically, emotionally overwhelming. And I say physically too, because we know that the body is heavily impacted and it sets off a whole cascade of very acute stress responses. Usually the individual is in a situation of being confronted with something that is hard for them to incorporate or hard for them to process. And in the case where PTSD develops, and it does not develop in response to all trauma, but when it does develop, it means that the body has been changed and the physiological response has been changed in some significant ways. So another characteristic of trauma that's one of the classic ones is also that it's the individual is in a circumstance that they have very little or no control over. And so that's part of what's shocking, overwhelming, all of those words apply. But I do want to say that trauma is a very individualized circumstance. Yes, we know that, certain events and certain experiences have high potential, and they're called potentially traumatizing experiences. And there are events that will traumatize or expose people, almost across the board. But some other events may be much more subjectively interpreted and experienced by someone that make them traumatic, whereas for somebody else, they might not be.
I have a question for you. So I work with a really acute population right now. And I think almost every single one of my patients has a history of trauma, whether it's undiagnosed or diagnosed. What can you tell us about the current prevalence of trauma today?
Well, this is my belief, and it's backed up by some of the research at this point, the epidemiological research. I believe that over the last 50 years, which is the time of contemporary study of trauma, that our understanding of what is traumatizing or potentially traumatic has changed dramatically and has expanded dramatically, so that we think that it's much more prevalent, or at least it's more prevalently recognized. But recent years, and particularly the COVID crisis, the climate crisis that's going on, that's getting everybody's attention, is beginning to accelerate or is accelerating. And all the follow-ons, the war in Ukraine, all the follow-on circumstances themselves can compound the trauma. So my area of study has been complex trauma, which has to do with repeated exposure, and often starting with child abuse and then building over the lifespan. But these new types are kinds of exposures that themselves are repeated and may become pervasive. So it's not just child abuse, which is where we started understanding complex trauma, but it's across the board. There are many circumstances in adulthood that have these characteristics of being repeated, entrapping, and involving interpersonal violence as well as impersonal kinds of events.
So, Christine, one of the things that has challenged me over the course of my almost 40 years of doing clinical practice is the identification and the working through of neglect, which to me, in many of my clinical experiences, is almost worse than physical or sexual trauma. And I don't want to say, I mean, I'm a little skeptical about, a little careful about using worse, but it seems to me that the toxic nature of neglect on the self, and sometimes it's benign, and sometimes it's rather malignant neglect. I mean, people who do and so as for the younger therapists who are watching us, or for people who haven't had as many decades in the trenches as I have, what do you suggest to us about how you identify that and articulate that? Because it's generally not narratized by the patient. They don't have a narrative about it. Usually been told in a way that, you were so independent at 3. I remember I would go to work and leave you home, and you were a little bit, you were a very independent 3-year-old.
Yeah. Well, first of all, one of my famous lines is, neglect has been neglected in our field. It has not been recognized as to its potential for dire consequences. And what you just described about the 3-year-old is one of the dire consequences, and it's related to detached avoidant personality style or attachment style, which is actually pretty dissociative. Meaning that the child has to put up a false self of pretending to be self-sufficient or taking care of the parent or being exceedingly self-sufficient. And then it gets reinforced, and characterized about the child, whereas there's no attention to what the parent did or didn't do in terms of being neglectful. So in some cases, we can recognize it very directly, a child who's, not clothed properly or not cleaned properly or whatever. But, when it comes to emotional abuse and neglect, we often, you're right, don't see it. And it can do and does do profound harm.
Yeah.
So I totally agree with you.
You're probably familiar with Perry's work in Texas, the psychiatrist who would work with really terribly abused children, and he described them just being alone all day long, while some poor immigrant.
Well, the boy who was raised as a dog is the title of his book.
Yeah,
very evocative.
But the boy raised as a dog had the animals around him and did better than the boy in the crib who had no one.
Right. Well, you're right. I mean, there are different kinds of stimulation, and we're talking about stimulation and appropriate levels of attention and response and reaction and protection and intervention, however you want to call it. But many of these parents themselves, you know, are sort of a blank screen and are impaired in some way. And I would like to add here, you know, I don't think we spend enough time thinking about parental impairment, including parental addictions, which result in a great deal of neglect.
Sure.
There was a recent article that just came out in Scientific American about the multi-generational transmission process of trauma. And what I thought was most compelling was the emerging data that shows that there are epigenetic changes in the genes of the parents that are passed on to their progeny. And so there is pretty strong evidence, and this is a major journal, Scientific American. In many cases, the genotype of the kids has been altered to make them more vulnerable to trauma.
That makes sense.
Yeah.
So it's not just a modeling and a reenactment, it's also may have a genetic biological generational effects, and why it's so important to stop it at the generations we can.
Right. Well, it also has another connection, the work of Rachel Jehuda with
that was her article.
Oh, it was. Okay, good. She studied children and grandchildren of Holocaust survivors.
Yes, that's her.
She was one of the first to identify these changes, but also that children sort of related to that, maybe very much more than just a little bit, is that the progeny, the first generation themselves often had PTSD responses from living with their parents. And they had not been particularly traumatized except for how their parents either interacted or didn't interact with them. And as you can imagine, some Holocaust survivors, because of all of their losses, never wanted to get or couldn't get close to their own children.
The attachment was destroyed.
As a means of you know, protecting themselves. And then the next generation, I've been reading a little bit about this, is that grandchildren have been now seen as sort of the rescuers in the family, trying to make up for. So it's very interesting to keep that research up.
Yes.
Rachel's been a pioneer.
Yes, and the complexity of this is enormous. And I often resent how people try to reduce it to such simple terms and simple ideas that, you know, you're traumatized. You know, if you weren't physically harmed, you weren't traumatized.
It's better. I think it's actually easier to be hit than to be locked in a basement.
Yes, because at least you know an action that shouldn't have happened.
And it's more over, and there is some connection down 6 hours in a pit is pretty scary stuff.
Yeah.
But you know, as we're talking about this, you know, it can be hard for people to hear it. As we're talking, I find I get upset. It's painful. You know?
Yes.
And I think that the more the pain of it and how difficult it is talked about, the easier it is for people to learn about it. Because otherwise, they're going to defend against pain and defend against knowledge of it. And I think that's one of the reasons why people don't want to look at this stuff.
Right.
I think that's such an important point, Michael. I was with a new woman that I've been working with earlier this week, and I was struck by her resilience and her goodness in spite of this horrible treatment. And as she was telling me her story, I was feeling so sad. And she's just such a lovely human being. And at the end of the session, I just said, "You are just such a lovely human being." And she looked at me and she started tearing up, and I just started tearing up. It was like that, just listening to what these people, and what is so horrific sometimes is the people that do. I mean, it's all across all cultural, generational roles. But it's often what really gets me is like when ministers and physicians and people who are in the community, highly esteemed, are doing this to their kids at home. It's just very hard to.
Well, you know, the opposite end of the spectrum that you're talking about, Jeffrey, is also studies of people who are abusers have found that the thing that's most related to their severity response is having been emotionally abused and neglected. And emotional abuse is seen as a potentiator of the responses. And it can result in turning that rage against other people and either, you know, using it as a way to reenact or to for mastery or a way to get back at
that's
be the abuser. Yeah.
So where does that idea come from, that the emotional abuse potentiates this phenomenon?
Research that Bessel did actually years ago. And there's a book that's just come out by some of his former staff members on emotional abuse and neglect, and really highlighting how that has just gone by the wayside and hasn't been recognized for what it is. And the first author on that book is Elizabeth Hopper. It just came out 2 years ago. I wrote the introduction to the book, so I know it well.
Yeah, is it good?
Yes, it is very good.
Thank you.
It's something like component therapy for complex trauma or something like that, but it was written about emotional abuse.
Yeah. Now, Jeffrey, to an example of this woman he was working with and who was upsetting, he found himself so upset, and they cried together. I wanted to see what you think about this issue of essentially being acknowledged. Jeffrey's emotional response validated her.
Yeah.
And how important is that in the treatment process? This is because these are people who aren't used to getting there.
Right. And I think that's a topic actually that is a really delicate one, and one that's quite paradoxical. And I would imagine, Jeffrey, that you know this patient pretty well at this point.
No, this was pretty. No? This was like the third session.
Oh my goodness.
No, it was She went very quickly deep. She has a pretty solid ego structure.
Okay.
She wasn't I mean, she a little dissociative, but was able to go.
Yeah.
She had done therapy before, so she had solidity. So yeah, it went very quickly. She went into it, and
then in that case, you know, it's a wonderful experience. And you know, what I was going to say is very early in therapy, for somebody who really has incorporated the messages of abuse, that you're nothing or you're worthless or, you know, you're a terrible person, to hear someone say you're a lovely person may be overwhelming and maybe too much for them. So that has to be delicately handled. But also, Jeffrey, you're talking about having a spontaneous moment with that woman, and she shared it. You both shared it, and so that was significant for both of you. And that's exactly the kind of thing that we would hope is happening in therapy, that the client is feeling recognized and regarded, well regarded. You know, I think one of the famous lines out of attachment theory and relational therapy is, "I can feel you feeling me." For a client to say that, you know, they've incorporated you and you've incorporated some of them, which is part of the at least as I view it, part of the healing factors.
Yeah, yeah.
That's a lovely moment.
Well, I mean, another thing that I said there is I have 3 daughters, and I just can't imagine that, you know, your own parents didn't have the opportunity to cherish you.
Mm-hmm.
The treatment was just so horrible, just so horrible.
So that makes me think of, you know, working with people who have been traumatized and have a history of trauma. Showing them compassion can go a long way, but also teaching them self-compassion. I find myself trying to teach my patients like we do a lot of short, quick therapy. So I was curious about what you feel like that role plays in people with trauma.
Oh, I think it plays a big role, but I have it's funny in hindsight, experience that is cautionary tale. I introduced that concept to one of my clients who I had seen for quite a while. And I said, you know, we're working on building some self-compassion. Well, she flung herself back on the couch. She just looked at me, like glared at me, and she started laughing hysterically. And she said, you really don't understand how bad I feel about myself, do you? And so that's the kind of boomerang that sometimes can happen with these clients. The good news about this case is the timing was such in her therapy that, yes, she had that reaction in the moment to see how I would respond. And I wasn't thrown by it. You know, the invitation is here for you to begin to develop some self-compassion. You've suffered enough. And over time, and by the time we finished our treatment, she had incorporated that. And in fact, I retired 6 years ago, and I hear from her routinely telling me about her successes. And she's had many challenges, and she writes to tell me how she uses what we talked about today.
That's amazing.
So it's sort of like what you're saying, Jeffrey. It like warms your heart, and it's very gratifying when it works. But
when it works.
This gets us into another topic that I was hoping we'd get into, which is a training issue. But if you don't have any understanding that for some of these clients, you can be the most empathic person in the world and compassionate person, for some clients, it's going to scare the daylights out of them, or they're going to push back, they're going to aggress against you. There's
can be a trigger, right?
Yeah, absolutely. I was just going to say there's all these fault lines that you can
it's like landmines that
they're landmines, right?
Definitely. Oh my gosh, yeah.
They're directions. They tell you which way to go.
Yeah. But if you don't get it, and you're personally offended by, you know, you've been trying so hard to be compassionate, and they blow you off. Like did, or worse, you know, she wasn't, I mean, she was contemptuous in her own way, but, you know, she wasn't aggressing towards me. But if you get an aggressive response or you get ridiculed, it's very easy to take that in and personalize it when it's not about you, the therapist. It's to be noticed as something about the process. So, you know, all of those finessed kind of points and understanding about that are really important for therapists to know, especially if they're working with complex trauma, and especially if it comes from childhood and these kinds of experiences that we're discussing.
Yeah, I wanted to ask you a question, and Elizabeth one also. I'm going to ask you first because you just brought this to mind, and that is that when people get really scared when you say something about that sounds tough, or you must have been very hard or something, and they just veer away. And when that sort of thing happens, do you try to shift and move to, well, when you see a puppy, you know, it's been hurt its paw.
That's a great question.
How do you feel, and what do you do then? How do you help take care of that puppy, or what would you like to have happen, so that they learn about talking about caring for something, and then about caring for themselves.
Right.
Step away.
Mm-hmm. Yeah, that's a great way of addressing that particular issue. But I think another thing that I've learned to do over time is to notice it and bring it to the client's attention, not to pressure them, but to say, you know, I've noticed that whenever we talk about this, you know, you veer away from it. Are you aware of that? So beginning to open the dialogue about how they're reluctant or resistant, you know, or scared, obviously scared. We haven't talked about another dimension, which is loyalty to perpetrators and loyalty to families. And that's another reason for minimization or avoidance is to not bring down the needed attachment figure due to ambivalent attachment or due to loyalty, often misplaced loyalty. So another way of getting into that question is you sound really loyal to so-and-so or to your family, but it sounds to me, and owning it for the therapist, it sounds to me that, you know, things were pretty rough in your family. Just leave it open.
Yeah. One of the things that I do in those instances is I do a little of that neurobiology stuff. I say, you know, without our attachments, we die. Attachment, maintaining attachment was evolved in us so that we could survive. So no matter what the attachment figure is, you're going to figure out how to maintain an attachment to that figure, no matter what, no matter how abusive they are, you're going to figure that out, how to maintain an attachment to that figure. And that is survival. That's not pathology, that's survival. However, at a certain point, that attachment may not be adaptive any longer because you don't really need that person. You're not a 4-year-old who's not going to get fed if you cry. You're not going to get hit if you scream. You're an adult now and you can take care of yourself and you have other people take care of you. So maybe that we can take a look at that. And so, you know, I think I think we all underestimate that drive that's so inherent in our species to bond and to hold the bond, and that we all have abandonment vulnerabilities to some. It's evolved in us to protect us.
Even if the, you know, losing a loved figure is something that we don't do easily. My mother's 101. About 2-3 years ago, she really began to fade. And I was really getting angry with her when she couldn't do things and couldn't think right. And it was only when my wife pointed out that, you know, ease up, you know, she can't do it, you know, and I was kind of shocked. And then I kind of realized that. And then I saw my cousins doing the same thing. I'd call them and say, you know, your aunt is your whatever is really, how's she doing? I say, she's really slipping, you know, and they'd say, gee, I thought she was pretty good. Because her social persona, if you didn't go right beneath the surface, was great. But underneath, she was
she was leaving.
Yeah.
And you were being abandoned.
I was not ready.
Yeah.
Well, we're never ready. We're never ready.
Never ready.
Yeah. Right.
So
that's, you know, that's another leads into another related issue from a different perspective, though, is one of the things that really gets to me in working with relational trauma and attachment trauma, as you're discussing it, is, you know, one of the distinctions we make with interpersonal trauma is that it's something that happens intentionally. And in sort of the Midland kind of cases where, or the moving towards a more severe direction of cases, it's the relationship that's used against the victim. The relationship is supported, the relationship is is misrepresented, and the victim is entrapped in that way psychologically. And so, you know, these great ambivalences or these great, you know, loyalties develop that keep things in place. And that's getting back to your very first question, Elizabeth. That's some of the things that we've been learning over the last number of years, the victim-victimizer dynamics and how they play in and how confusing they can be for what's supposed to be a credible authority figure, whether it's a parent or whether it's a therapist or whether it's whoever is taking advantage of them. That's one of the things we learned, and we incorporated into our book a lot of information about the grooming process and the use of the relationship, so that there is this, you know, really ambivalence about being able to see it straight. And Jennifer Fried has talked and done a lot of research on betrayal trauma, and the very betrayal of the relationship and the role of the relationship is part of what's traumatic and part of what gets in the way of healing process, because you got to give that up.
Mm.
Yeah, it's very hard. You know, I remember, this gets back to the training issues, and when you're getting trained initially, you get handed often some very difficult patients, and something crazy about it, but that's what happens.
You don't know what to do.
Well, it's you may actually, just because you're a decent human being, know what to do, but that's not what they want you to do.
Right.
So,
right.
and I remember emergency room work. You just become cold as can be, because you got to get through it, and you got to be strict, and everything has to move along, and so, you know, this is gallows humor. Now, working in an inpatient facility, there's some of that, and so I'm wondering, how do you know, you're aware of all the trauma, and yet, you know, there's a tremendous pressure on moving people along, and not in a gentle way. They got to move through this thing.
Mm-hmm.
Is that being dealt with any better today?
That's a great question. And before Christine answers, I want to say that all four of us have experience working in inpatient units, so we all know what that's like.
Mm-hmm.
Know what it's like to have people in my era in body bags and 4-point, know what it's like to put people into that. Anyway, so I just wanted to throw that in, but Christine, you want to?
Well, I co-founded and co-directed Specialized Trauma Unit for 16 years, and we practiced trauma-informed care, or at least we tried to, and we did a lot of staff training around that. And it was interesting. This gives you an idea of my age too. Same thing as what Jeffrey's saying, but we started out having a 28-day length of stay for our patients. That was routine. And we had all kinds of adjunctive therapists and therapies, and managed care killed us. I mean, we went from 28 days down to 12 on average, which is really, really high for, you know, a length of stay. But you're absolutely right, Michael. I mean, the whole pressure of, I called it a conveyor belt. Clients would come in very acute crises, and we'd have 12 days to try to get through and give them some skill building or whatever. And then they'd be gone, only to be followed by another person on the conveyor belt. So one of the things we learned is it's very easy for the staff to get caught up in exactly what you were saying, the coldness, the routineness, and not treating them individually in the way that our philosophy says we're supposed to. And it's very easy to become hopeless also. Yes. I think it's really contagious. Jim Chu talked about that a lot, and how contagious it is if we're not careful. So I think specialized attention to the staff, to those kind of dynamics, making it okay to talk about, making it okay for mental health days for the staff, if they're feeling like they're getting burned out before their vacation time, whether the work is right for them. I also feel like not everybody can do this work or should do this work.
Right.
And I personally, with one member of my staff, experienced the worst burnout I've seen. And it was one of my clients that I had hospitalized, and the client was so mistreated on my unit that she came back to individual therapy, and she had a cut about this long on her arm that she had dug into herself, and she had not self-mutilated for, I don't know, maybe 20 years.
Wow.
And when I took one look at her arm, I said, what on earth happened? And this staff member attacked her verbally and in front of everybody, shamed her.
Oh
and
my gosh.
Yeah.
You
Wow.
anticipated something that I wanted to bring up, because it's of great concern to me, and that is that I have found that I do not hospitalize patients anymore, because what my experience has been over the last 10 to 15 years since the ascendancy, or maybe more, since the ascendancy of managed care, is inevitably when I have someone that goes in the hospital, psychiatric hospital, good hospitals, they come out worse. The hospital treatment these days is traumatizing, and they come out in worse shape than they went in. And so I have developed a much higher tolerance for suicidal patients, and for patients who are on the edge.
Teetering.
Yes, because I have to spend so much time after they get discharged.
Getting them back to where they.
Some of these are really high functioning people outside, and they have something happens, they have to go in, and they I don't know if you're working in patient now, Lizzie, so you're seeing it from the inside. But what about you, Michael?
But there's another very important historical thing that has just happened this year that our listeners should know about, that all of the specialized units that have been available, and they have been shrinking and shrinking and shrinking since their numbers have been shrinking since my program. We started our program in 1990, and it's one of the few that has changed hospital, and it's now still running. But every other major program that I know of this year has been so constricted by managed care and literally by stupid administrators and stupid medical professionals that they've all closed. My program, it was so bad at the hospital we were at that the whole staff quit, and then they moved elsewhere. And there was just a Washington Post front page article about how that particular psych hospital was in so much chaos right now that it's not safe for the staff.
Wow.
Much less the patients. So, you know, these were perfectly well functioning programs that were helping people.
But what happened?
And they're gone.
What happened, Christine?
Well, I think I can't even say it's a misunderstanding of trauma, because several of the programs were within healthcare corporations that had a number of trauma programs, and they were doing fine. I mean, my program was economically supporting the hospital because we had a pretty good rotation.
You had a profit. Wow.
Yeah, we were at a small hospital, but we had a fairly, robust program for a long time. But I don't know what it is these days, except the economics. I'll give you another example. By the end of the time my program closed, when all the staff retired or removed themselves, there were no night nurses. Usually there's a night manager, a night nurse manager.
There has to be, I thought.
Oh no, they didn't do that anymore.
Wow.
CCH requirements?
They had a night nurse for like 2 or 3 units who rotated. I mean, they get around these things, but there's not enough staff time. There's not enough support. And what happened is You know, the therapeutic milieu, when it's not being managed, becomes dangerous. Patients were getting assaulted, you know, so then you see more draconian things happen, you know, sort of what you're saying, chemical restraint or putting a patient in a, you know, a padded room, you know, and that's supposed to be treatment.
Yeah, I definitely see patients who say that they feel more traumatized by being, if a unit is highly acute, if there's a few psychotic people or aggressive people. I know both our acute units, we have two, are really acute right now, very violent. It's everyone feels unsafe. The patients who they've been there maybe for a few weeks and they're pretty much at their baseline, they're stabilized, waiting for discharge. They're like, I feel scared. Like, I feel like I was doing well and now I'm not doing well anymore. So at least at where I am now, we see a lot of a really negative influence from other patients who are having their own issues and causing other people who have been relatively stable to feel not stable anymore. That's a big problem.
That's why we opened our unit in 1990. It was one of the first. It's another one of the first. And it was because several of us, at the point at which we had to hospitalize someone, they were being faced with out of control manic patients, schizophrenics, dangerous people. And, you know, so what we wanted to do was have a contained, and we did. We had a contained, relatively safe, trauma-informed, and all that that expertise is going out the window. And so for the next person to start a unit like this, they're going to have to start almost from scratch.
Oh my gosh.
Yeah, which is really unfortunate.
And, you know, I recently had to contend with one of these decisions where you have a family member who is really disturbed and abusing all kinds of substances, been through all kinds of systems over and over and over and over again, and aging parents who were increasingly being threatened. And talking about, you know, the people having a sense of connection and not wanting to give it up, and yet clearly it wasn't working. And the hospital's no picnic, but clearly this person needed to be removed from the family at this point. And you know, you could see the loop going round and around and around, out again, and then what? And the parents want to take care of the child, but the child is going to just do the same thing again because everything's ingrown at this point. All the patterns are set. You know, you almost have to have a family program, to make something like this work. It'd be very hard to take to have one person's removal work, because you've got to change the whole system. And I'm wondering how that plays into, the treatment of traumatized patients. Sometimes you were kind of saying that sometimes you just have to say goodbye, but sometimes, where do people go?
Right.
No, so I did a lot of work training therapists who worked in a cardiology unit years ago. And I have seen a number of cardiologists and cardiac surgeons. And when I hear them talk about what a patient with heart disease gets, the amount of money that's spent from the medical system, it's enormous. Just for a day of stress tests and echoes and all that stuff. And I just wonder, why do we not perceive people's psychological health and well-being in an equivalent position?
It's a hefty question.
Hasn't been talked about until relatively recently. It's always hidden back That's not acceptable. It's just, we just don't have that. All the trauma, all the child abuse was being hidden, all mental problems are hidden. I mean, look at all the surveys that were done in the 1950s and 60s about the incidence of different mental disorders. And society's reaction was, those people doing these studies must be nutcakes, because they're basically saying it's us. And so it's getting people to begin to realize that we're all, we all have issues. What was it, Leighton's big study in Canada where they looked at a catchment area of like 20,000 people. You could diagnose without any difficulty, just by 95% of the population, from minor neuroses up through alcoholism, psychosis, and what have you. And then if the last 5%, I'll forget about it, it's a long story. But in a nutshell, about 1% you couldn't find that there wasn't protection.
So the other issue that annoys me and perplexes me is, why do so many people in policy and in medicine and the public think that what we do is just sitting and giving advice, and seem to have no understanding of the complexity of what it takes, the knowledge that someone like Christine has, and you, Michael, and the years of experience and expertise to work with people in an effective way. Why is that so? Why are we so demeaned as a mental health?
Nobody even people who have had treatment avoid talking about the treatment. In my decline, I've become to talk more and more about my own treatment and my own problems, and I think until people talk about it just like they talk about their heart disease and everything else, it's not going to get it.
So you're saying there's still stigma?
Massive.
Oh, yeah.
Look,
Oh, yeah.
but I think some changes are coming down the pike with the number of athletes that these days that are willing to take their mental health seriously and talk about it and bring attention to it and go get help. And also the number, the tragedies this spring of, I think it was 4, top female athletes, all of whom committed suicide because they were so beset by the need to be perfect, and they at some point didn't see any alternatives. So that's learning the lesson the hard way, for sure. But I think what some of the athletes are doing in terms of opening this up is allowing the public a different snapshot. And I think as we're talking about trauma more openly in our society, that's the good news. The bad news is, I agree with you that not everybody understands much about it or understands PTSD, or they make the mistake of saying if you had trauma, you automatically are going to have PTSD, which of course is erroneous. So there's a great deal of need for public as well as professional education.
Well, I also recently heard some statistics saying that I think it was estimated that there's a shortage of behavioral mental health clinicians, and about 40,000 fewer than we need to just provide
40,000.
40,000.
Wow.
I think it was 40,000. And the level of training that most therapists get is pretty minimal. I mean, you can get through a program and hang a shingle out without a lot of training and experience. You can be an LPC or a licensed alcohol and drug counselor, and you can be treating pretty significantly ill people without substantial training and education and expertise.
Look, it takes long. You can be a natural, but you still have to do a lot of work, and you could to get any skill. It takes time. It's not something you just learn a few techniques. And you have to face things about yourself that you didn't want to face. And you have to keep learning. So we live in a society where, it's almost half the people, essentially, want someone to be president who says, I didn't lose an election. I cannot be a loser. I am not a loser. I'm not a loser. He's so terrified of being a loser. He's so traumatized.
You're right.
Which is, he's doing all these things to cover it up. And so that's what's kind of going on, I think, with huge groups in our society. All these rampages are because they don't want to be losers. They don't.
He's modeling it to everybody.
Right.
Yeah.
Right.
Yeah.
So it's not, and I mean, look, the police have massive problems with this stuff because they're they want to be good and tough, but they have to deal with problems where you can't be so untough. You got to be tough, and you can't win. Whatever you do, it's the wrong thing. And so it's a lot of things are being shattered. I mean, like the police get attacked, the FBI gets attacked. It's just.
Well, and I think that's what, Christine, you were talking about earlier about the climate change and the pandemic. And the other research that I read was that the use of psychotropic medication for attention deficit disorder, depression, and anxiety is up way high than it was pre-pandemic. So that's a sign that people are suffering and they're looking for something. And often medication is the easiest.
Easier to get treatment for.
Yeah.
1 minute to take a pill.
Yeah.
And these people are hard, double jobs.
Well, Michael, you get me on my my bandwagon here, because one of my issues has been to really start calling out. I'm a psychologist, calling out psychology, but all of the professions and medical professions too, Jeffrey, as you're saying, to start to get educated about trauma. And for those of us that go into a specialization of trauma treatment, we need much additional training. It's not okay to just fly by the seat of our pants, which is, I have to say, that's how I started. There was no literature. I learned by doing, and that's not the best. I mean, that can go okay, but it's not the best way to learn. It's not a systematized, organized way of learning. And I just saw a statistic that just shocked me, that approximately 5% of clinical psychology programs give any attention to trauma 5%. In the curriculum. And it's also, the reasons are, there's no room in the curriculum. Well, we've had room for diversity issues, and all of these issues interconnect. So, it just doesn't make any sense to me that we don't incorporate them at the very least, and that some programs develop that specialize. And I was involved in the APA effort to develop competencies, trauma competencies, and it's an APA policy, but it's not being incorporated. So what's the use of doing all of this stuff?
You have to, this sort of thing, having this kind of material on the web begins to give people who aren't getting the training they need a toehold. They can see there are things they can learn. Go to StratSci can learn some, but the point is that there's a lot of things that people need. And we are in this unique position today to make use of all the wonderful media and things. So the more we do things like this, the more we provide it to the public, not just to the professionals. This is my beating my own drum right now, because I think you have to get the professions to change and to move away from their comfort zones. You have to get the public interested, and you get them interested, and changing things more rapidly. Because otherwise, people protecting their grants, they're protecting their position, they're protecting the pyramidal training structures that have existed forever, and nothing.
Yes, yeah. And speaking of good content, I just want to let our listeners know that Christine has written a wonderful module that for Strat Psych, our online learning platform, that really curates in a very succinct way a lot of what she's talking about today. But I have a comment from one of our viewers. I think doctors used to be more of therapists, look at patients holistically, spend time with patients, work with them and their families. Now they can't, because they can't spend that much time with clients. So they aren't going to recognize the importance of what we do, or they would be admitting there is something wrong with their system, which there is. Thank you for the question, Diane. More questions are welcome. And we're gonna stop at 7, the recorded version, and we'll continue in the unrecorded version. So hang around after.
Have a discussion.
Yeah. You know, I have a little bit of disagreement with you with what you just said, Michael, in terms of if the public takes it on, the professions will do it. I think that the attention to trauma has just, you know, multiplied, and you know, we're well aware of it, with problems with that awareness that I mentioned earlier. But you know, I think your point about professionals who don't want to look at their own history and what it takes to get trained in this, additionally to some of the baseline training, you know, I just get very frustrated thinking it's not going to change. The public knows what's needed in terms of knowing much more about trauma, but you're absolutely right. They can't find resources. And I get calls even today. I've been semi-retired now for 6 years. And I get calls and emails all the time from people who are desperate, saying, I can't find a therapist who knows how to help me.
Yes, that is so true. Here's a resource I'm putting up there, a book for the public that it's great for clients.
Yeah.
Every Memory Deserves Respect by Michael Baldwin and Deb Korn. Great book to help people understand trauma and also EMDR.
Yeah. And if I can blow my own horn and talk about my consumer book too.
Yep.
I have a book that's called It's Not You, It's What Happened to You. And it's an expansion of what I wrote for your website, Jeffrey, and it's about 100 pages. It's on Amazon, and I wrote it specifically for consumers and their loved ones. You know, Michael, your point is also very well taken about family members need to be involved very often and don't understand. And so this is a way to try to help them to understand. And I've gotten the feedback that, like the book that Jeffrey just mentioned, that these are helpful resources to help people understand what's going on and where they can get help. Hopefully that they can.
So in the last minute, Dr. Courtois, can you tell our therapists out there who are in the trenches something that they can take with them or empower them?
Absolutely. There are great.
I knew you could.
There are great rewards to doing this work, and you've heard some of that interspersed by, you know, throughout this hour. There are also great challenges in doing this work. But a couple of recent surveys, I think, of therapists have been really, really important, with really senior therapists who have been in the trenches for a long time, saying that as they've learned and as we've written books and as we've got a body of information now, many of these individuals sort of have a trail that they can follow, or a guidepost that they can follow. And then in doing that, they have seen that their clients' growth, and they parallel their clients' growth with vicarious post-traumatic growth. So we talk about vicarious trauma, and that happens too. But we also know that doing this work and seeing somebody come out the other end in a better place is a wonderful experience, and it is regenerative for therapists. So there is a lot of hope, and our job is to hold the hope. And the other thing I would say is to maintain connections to other people. Don't be afraid to seek consultation and supervision, and with peers, and also with more expert practitioners.
Thank you, Christine, and we hope you come back soon. And for those of you who are watching and hang around, we're still going to